And okay. Can you see my screen, Eric?
Yeah, it's good.
Okay,
Yeah,
great.
yeah.
So thank you for that. That was really a great introduction. Makes me really happy to sort of have the north of the border folks recognize what I've been doing down here for all these years as well. And so the title of my talk is Technology in the Cath Lab: Expensive Toys or Cost-Effective Therapies. And really what I'm going to be doing is talking for the first 20 minutes or so about some basic methodology and technology assessment and cost effectiveness analysis, which some people know, and Canadians, I think, know it better than most Americans. And then I'm going to transition into kind of some worked examples from my own research that will hopefully bring some of the ideas home. These are my disclosures. I do receive research support from a number of device and a few drug manufacturers and serve on some advisory boards. So the whole idea of cost effectiveness in cardiology has really come home over the last 20 to 25 years. In cardiology, we really have been blessed. We are blessed by a number of amazing, new drugs that have come along, as well as devices that have come along that have really revolutionized the care of cardiovascular disease, certainly in my lifetime. And this is really the last 20 years of major device advances in cardiovascular medicine. And what's, what I've tried to list down here on the left-hand side is the trials and the devices. So we have ICDs, we have LVADs, biventricular pacing, drug-eluting stents, and TAVR. We have all of these wonderful device advances. And these things come at a pretty hefty price tag. You can see the price tag, at least in the United States, especially when these were first introduced. These are really just approximate numbers for the purpose of the example. And then here in the middle column is really the numbers of affected patients. And what starts to get really scary is when you multiply the numbers of affected patients by the cost per patient, and you get into the tens and 20s of billions of dollars of expenses. And so this really is emphasizes why in cardiovascular medicine, it's so important for us to think about the costs and the value of the therapies that we provide. And so, as I mentioned, I'm going to spend the first 20 minutes or so just kind of going over some basic blocking and tackling and the concepts that underlie economic evaluation of medical technologies. And if any of you took economics like I did in college a long time ago, you took economics 101 or economics 1, whatever college you went to, and you learned about a fellow by the name of Adam Smith, who was really one of the forefathers of the whole theories of capitalism, and the basic economic theory that he espoused and that most economists understand is that resources are limited, yet we are human beings, and therefore our wants are unlimited, but nonetheless, somehow these resources are allocated and decisions will be made. And this really is, 250 years ago worth of economic theory, but things haven't changed very much in the last 250 years. And to make that very clear, here's a slightly more modern version of the same material. You can't always get what you want, but if you try real hard, you might just get what you need. And that, of course, is Economics by Mick Jagger and Keith Richards. And Mick Jagger, as everybody knows, is the world's spokesman for TAVR at this point, having gotten his TAVR a few years ago here in New York City. So that's really is the underlying principles of economics. In medical economics, the most important concept, the one to really keep in mind that everybody needs to walk home from this grand rounds remembering, is the difference between cost effective and cost saving. Sometimes these get conflated, but they're not at all the same. This basic figure tries to make that very clear. So when we have any new technology or new therapy that comes along, it really comes with two different dimensions. We have the traditional medical effectiveness, and a new treatment could either be more or less effective than the available alternatives. And then we have the cost dimension, and that new treatment can also be either more expensive or less expensive than the available alternatives. Now, sometimes we have something that checks all the boxes and resides down in this lower right-hand quadrant, where it is both more effective and less expensive than the alternatives. And this is a no-brainer. This is the things that we all want to do for all of our patients, because not only does it improve health and save lives, but it puts money back into the healthcare system. Occasionally, something comes along that is both less effective and more expensive than the available alternatives. And these get dropped like a hot potato. There's no value whatsoever in these types of therapies. But the challenge for us in medicine is that most of our therapies are in these two diagonal quadrants. And in particular, most of our advances are in this upper right-hand quadrant where we were gaining some effectiveness, but we were also having to spend more money to achieve that. And that's where the whole idea of understanding cost effectiveness and value of therapies comes into play. Now, there are several different ways that one can assess the value of medical technologies. One of them, just to highlight it very briefly, is the idea of cost-benefit analysis. And this is different from cost-effectiveness analysis that I'm going to talk about in just another second or two. But cost-benefit analysis has never really caught on in the medical field. It gets used in other areas of value assessment. But the idea here is to have an analytic approach that can determine the net benefit of any healthcare program or treatment. And the general approach is that the health expenditures and benefits are both measured in the same unit, that is dollars. And if we can do that, which is a big if, the net economic benefit can then be easily calculated as the difference in benefit, comparing the two, minus the difference in cost. And if you can do this, if you can value everything in dollars, then the decision rule, if you're a payer trying to decide whether you should cover something, is very simple, which is that any treatment program is worthwhile if the net benefit, the net economic benefit, is positive. As you can imagine, the challenge here is how do we value health benefits in dollars? So the advantage is that the trade-offs between costs and benefits are explicit, and the decision rule is exceedingly easy to apply. But the disadvantage is that it's difficult for us, for everybody really, to value health benefits in economic terms. What's the value of a life saved? What's the value of pain and suffering? There are a number of approaches that have been attempted over the years. For example, you could say that someone's life is as valuable as their future stream of income. You could say that we could take a willingness to pay approach, and we've actually done this for some technologies. How much would you be willing to pay, if you had to pay out of pocket to achieve these health benefits? But as you can imagine, these types of approaches really tend to undervalue the lives of the poor who don't have a lot of income ahead of them, the elderly whose income is all behind them, or the very young or the unborn whose income is so far out in the future that it is very heavily discounted relative to present value. And so for these reasons, this really has never caught on in medicine. And what has caught on is the idea of cost effectiveness analysis. And cost effectiveness analysis, the goal here is to allocate our health investments or expenditures in order to maximize the aggregate health benefits to society, subject to the constraint of a fixed healthcare budget. Now, that's a big mouthful. What it really means is if we have a certain pot of money to spend on our healthcare, our healthcare budget, and we apply the lessons from cost effectiveness analysis, we will gain the most health for whatever our decision-making unit is, for our society, for our health plan. The idea here, and really why this has caught on, is that the costs and their net health benefits are measured in relatively natural units. So the costs can be measured in dollars or yen or British pounds, whatever you like. And then the health benefits can be measured in things like the number of lives that are saved or the number of years of life that are gained. If you're saving somebody's life who's going to live for many years after that, you can even look at intermediate health outcomes like complications prevented or even biomarkers if you like. And then the idea is that the cost effectiveness ratio, which is the outcome of a cost effectiveness analysis, is calculated as the difference in cost comparing the new treatment to the established alternative, and then divided by the difference in effectiveness, again, comparing the new treatment to the best alternative. Now, again, this sounds fairly simple conceptually, but the challenge, the devil is always in the details. And so the first thing we need to think about is that numerator. What goes into the cost? So obviously, the costs include the direct cost. So if it's a device, if it's a stent or something like that, well, it's the cost to purchase that. But it's also the costs that go into delivering that aspect of care. So the labor and the equipment supplies. So if you need, ancillary balloons and wires and, X-ray equipment and contrast, all of those things are part of the direct costs of delivering a stent procedure. Then you have the indirect costs, which also need to be accounted for. That's what your hospital thinks of as overhead. So rent and depreciation, maintenance. It's the office of the hospital CEO. It's all the nurses and the technical staff and the house cleaners and the cafeteria. All the things that go into delivering that service that aren't necessarily directly consumable. Then you have to think about a couple of other things very importantly, and these become very critical when we're talking about some of our interventional cardiology treatments, the idea of induced costs. And induced costs are the downstream effects in costs that are either incurred or avoided. So let's say we again talk about the drug-eluting stent example, and you need to take 3 to 6 or 12 months of dual antiplatelet therapy in order to keep that stent from clotting. Well, that's an induced cost. If that stent then goes on to develop restenosis and you have to redilate it or put in another drug-eluting stent, that also is an induced cost. But there also could be induced cost savings. Let's say that patient manages to avoid a bypass operation for the rest of their life. That's also some cost savings. So induced costs are very, very important and need to be considered in any cost effectiveness scenario. And then obviously we also can consider things like productivity costs, both on the part of the patient as well as on the part of their family if the family has to deliver informal care. So the cost side of the equation has a number of complexities that we have to think about when we're trying to understand the value of our therapies. Then what about that denominator? What goes in the denominator? So classically, if you think about it and think about, let's imagine a treatment. Let's say this is a heart failure drug, and the upper curve, the lower curve here, is standard care. This is a survival curve, and then the upper curve is the survival curve after giving the patient, a new drug. Let's call it an SGLT2 inhibitor or something like that. And then what we want to put in the denominator of our cost effectiveness ratio is life expectancy. That's the typical denominator, and that is the area under the curve, or the incremental life expectancy from adding that new drug is actually the area between the two curves. And again, we can calculate this. Sometimes we have to do modeling to extend our clinical trials to do this, or we have to do modeling when we have surrogate outcomes. But the idea is to calculate the area between those survival curves and to use that as the benefit that goes in the denominator of our cost effectiveness ratio. And ideally, we want to do something called quality adjust the survival difference. And that leads us to the idea of quality adjusted life years. And quality adjusted life years really are the standard metric that we use for measuring health benefits. And this is just an example that I worked out, but quality adjusted life years is a metric for combining quality and duration of life into a single measure of health effectiveness. And it wouldn't exist if we didn't need to do economic analyses. But just to give you an idea of what this, the concept here is that we're weighting time by a factor we call utility. And utility is really a preference measure. It measures the patient's preference for their current state of health relative to perfect health or the worst health state possible. So just to put some real numbers behind this, let's imagine a patient, a 55-year-old man who comes into your office initially and he's in pretty good health. He lives for 3 years in good health, and then he begins to develop severe angina, which really limits his activities and his enjoyment of life. But for some reason, he doesn't come back to you for another 3 years, lives for about 3 years with that severe angina, finally comes back. Eric does a Cath on him. He finds a severe 3-vessel coronary disease. And then Cohen does a bypass operation on him and reduces his angina to very mild angina. The patient lives for another 5 years in that health state, and then unfortunately has a stroke, and a year after the stroke, the patient dies. So this patient has lived for 12 years, but they haven't all been equally good. Some of them have really been in excellent health, and some of them, like the years with severe angina or after the stroke, have been in rather poor health. And the idea of quality adjusted life expectancy is literally to rate that time by this utility factor, to add up the areas of all these squares, which is what I've done here in this right-hand corner. And we would calculate that this patient, even though they have lived for 12 years, have experienced 9.9 quality adjusted life years. Now, what does that mean? Another way of thinking about that conceptually is if you laid this out for the patient and you could, tell him with certainty that this is the scenario that he would live through for the next 12 years, and you said, you could live 12 years with these series of events, or you could live a shorter period of time, but in excellent health for that entire period of time. This patient would value these 12 years as the same as about 9.9 years in excellent health. That really is conceptually the idea of a quality adjusted life year, which is our standard metric that we use for valuing health. And the nice thing about quality adjusted life years is we can talk about it for really any health state. We can talk about it for angina. We can talk about it for severe mitral regurgitation. We can talk about it for heart failure. We can talk about it for breast cancer or hypertension or any other sorts of things. So it's really is a metric that spans all of the different conditions that we can think about investing our money in. So we've talked about the numerator of the cost effectiveness ratio. We've talked about the denominator of the cost effectiveness ratio. So what do we do with this number? We can calculate it, but what do we do with it in order to help allocate our resources? Well, the decision rule, at least in theory, that we use to apply cost effectiveness analysis, what we would want to do is to calculate that cost effectiveness ratio for all of the different ways that we could imagine investing our healthcare dollars. And then we want to rank them in order of increasing cost effectiveness ratios. So we start with the programs that save money and save lives. These are the no-brainers that add money and value back into our healthcare system. Then we start to go up and up and up. We start spending a small amount of money to gain a large amount of quality adjusted life years. And we go up and up and up that rank list until our healthcare budget is entirely exhausted. And if we could do this, in theory, we would then have spent our healthcare dollars in the most efficient way possible. We would have gained the most value for our society. Now, practically, we really can't do that. Practically, what we end up doing is resorting to something called league tables, which are really rank lists of other cost effectiveness analyses that have been done. And in many societies in Canada and the United States, there are some general recommendations for about what thresholds ought to represent high value. In the United States, based on this ACCHA guideline document that came out about 5 or 6 years ago, generally treatments that have cost effectiveness ratios of $50,000 per quality adjusted year of life gained or less are considered high value. Intermediate value, which is also in many cases a value that we will spend money on in the United States, is between $50,000 and $150,000 per quality adjusted year of life gain. And when we get up here to the low value above $150,000 per quality adjusted year of life gain, those are considered to be poor value, and we would be better off taking the money we were spending on these types of therapies and investing it down here, where we'll gain a lot more health for our society. So we have these thresholds. Ideally, I would have drawn these with sort of blurrier lines because they're not absolute thresholds, although again, in some countries like the UK, there are pretty strong barriers. If you can't beat this high value threshold, you really have almost no place in the National Health Service. I think Canada is kind of somewhere in between, where this work is definitely used in Canada to help allocate resources, but perhaps not quite as rigidly as in the UK. A couple of other basic points, and then we'll go on to where cardiology really intersects with this. So one very important point, especially in the United States, but I don't think it's any different in Canada, is that cost effectiveness depends on perspective. This is very critical. Whenever you start a cost effectiveness analysis, it's critical to define your perspective as the first thing you're doing. And to make this clear, here's a nice US example. So let's imagine a typical 40-year-old man who comes into your hospital with unstable angina. He has a cath, and it shows that he has a high-grade LAD lesion and undergoes a successful angioplasty and a couple of drug-eluting stents. He ends up spending a day in the CCU and then 2 days in the step-down unit and is discharged home on hospital day 4. Now, here's where it diverges from Canada, because several weeks later in the United States, he gets a hospital bill, walks out to his mailbox, and there's a bill out there for $19,000, and his HMO covers this in full. So the question that we ask from this very standard scenario that we see all the time in the United States is, how much did that hospitalization cost? And the answer is that it depends. It depends on who we ask. So if we ask the patient, just like in Canada, the patient would say, well, my HMO covered the whole thing, so this was free to me, and just as it would be in Canada with a national health system. What if we ask the HMO or the third-party payer? Well, the bill says $19,000, but in the United States, the HMOs all negotiate different rates with the hospital, so maybe it's $10,000 or $12,000. They don't really pay what's on the bill. What if we ask the hospital? Well, the hospital, it cost the resources that went into taking care of that patient. So it cost the stents they received, it cost the intravenous medications, they cost their meal, it cost some of the overhead to run the cath lab. All of those things were the resource costs that went into taking care of that patient. And if we ask society, well, it cost the hospital, it costs the same cost that it cost in the hospital, but it also includes the downstream costs. So if this patient needs to take dual antiplatelet therapy for 6 to 12 months, well, that's an additional cost. If he comes in with a GI bleed because he was taking dual antiplatelet therapy, that also is an additional cost to think about. So we have 4 different perspectives here. They have 4 different answers, and they're all correct. So again, it's very, very critical whenever we think about these things that we think about them very clearly in terms of these different perspectives. And it shouldn't surprise you if you get a different answer looking at the different perspectives. And very commonly, the perspective where it's very different is in the United States, at least, is the hospital perspective versus the societal perspective because of the way reimbursement and other sorts of things work out. Last point before we go on to some of the real cardiology here. And this is, again, one of the real critical ones for those of you who are going to be going into, academic medicine or doing research or running a company, whatever you're going to be doing. Something very critical to keep in mind is that treatments aren't cost effective unless they're effective. Again, just think about that in terms of the denominator of that cost effectiveness ratio. If that denominator is 0, then it's, the cost effectiveness ratio is not well defined. And this is relevant because in my line of work and what I've been doing for the last 20, 25 years, not a month goes by without some company or some person, emailing me or coming up to me at a conference or something like that and saying, Dr. Cohen, we hear you, really have an interest and a passion for cost effectiveness analysis and technology assessment. We've got this great new device here, and we think this is going to revolutionize the treatment of heart failure, and we want you to help us show that it's cost effective. And I say, well, that's fantastic. Do you have, where's your evidence of, effectiveness? Do you have your data to prove that it's effective yet? And they say, well, no, we're just designing our pivotal trial. We'll have that, in a few years. And I say, well, then you come back to me in a few years when you have your data of effectiveness and we can talk. But until then, unless you're planning on giving this away, we really don't have a lot to talk about. Effectiveness really is the foundation of cost effectiveness. It's not cost. And we'll come back to that in a little bit. So,
David, I wonder, there's some question in the chat room. I wonder if we can take a couple of questions. Eric, do you want to start first? I know Brian, Courtney also have questions. Maybe Eric, you can go first.
Well, I'll just maybe drive you crazy, David, with a philosophical question before we move on. But, it's interesting because you highlight Adam Smith and the ideas of capitalism and liberalism and the value of the individual. And yet in your definition, you talk about cost effectiveness being assessed as the aggregate value to society. And in medicine, we always have this tension between the needs of the individual and the needs of society. And to me, this expressing things in a cost effectiveness ratio kind of just illuminates or magnifies that tension. And how do you, just give us some thought on how we deal with that and resolve that?
Right. So that's always, usually that comes up at the end. You're asking it a half hour too early, but but it's, it's absolutely correct, is that, cost effectiveness analysis is fundamentally, a utilitarian concept. It's about, it's the average, and it doesn't take into account the individual, and it doesn't even take into account an aggregate, the distribution of the benefits. It is agnostic to those things. And so that's why it's not, it's not the be all and end all of all, any type of decision making. In terms of reconciling the aggregate versus the individual, that is the tension of all of, economics. And the only way that I've, been able to really conceptualize that is that, at the physician level, we want to be doing all that we can for the patient who's in front of us. That's the Hippocratic Oath. That's our mission. And the economics, so you should not be thinking cost effectiveness really, not very much, at least as the individual, even in a country like Canada with a single payer healthcare system, where, where these come into play is really developing our guidelines, developing coverage, deciding what it is that as a society we are going to afford and cover, and to make informed decisions about that. The idea being, if you're going to ration care, you might as well do it rationally. And this is gives a structure to that. So you can't get rid of the tension. There is always the tension between the individual and the society. This puts a structure on it, I think, which is what you alluded to. Does that help at least? It doesn't make it any easier, but at least it tells you why we're doing it.
Yeah, it'll do until we can get to the bar after the talk and
okay.
argue it out. Yeah.
Brian, do you want to go ahead with yours?
Sure. Hi, David. It's Brian Courtney here. Harendra's heard me talk about this a few times, so he can probably guess what my question is. But as an example of cost effectiveness, there's intravascular imaging. And just as a disclosure, I started and helped run an intravascular imaging company. And you've got a lot of colleagues there in St. Francis who are intravascular aficionados. So I did a back of the envelope calculation about 1.5 years ago, and figured that if intravascular imaging saves 1 life out of 100 per cases that it's used in, there's data to support that. and it costs an extra 15 minutes in the cath lab and $800 for the catheter, you're looking at about $1,300 or $1,400 per catheter. And then when you look at reduced readmissions and the potential life savings from it, it comes out as well below $25,000. And then just about 4 months ago, a group out of Australia did an analysis based on their own healthcare data in Australia, as well as some randomized trials out of Asia recently that showed some benefits. And they had intravascular imaging for all comers having an ICER of $12,000 US. So that's one which is like, that's a pretty favorable, very high value on the scale that you showed there.
Right.
And yet, you know, when I talk to the people at the big companies that do intravascular imaging, and we all sort of bang our heads as to why the utilization in North America is 12%. You know, is something out of kilter there? Is there something that the evidence is not good enough? Is it because of nature? What's sort of your thoughts on that?
So yeah, I mean, I know that paper well. I reviewed it like 3 times and wrote the editorial on it. So I know that paper very, very well. And it's a good paper. I think, you know, and I think the analysis is sound. So I don't think there's a problem with the analysis. I think there are, you know, there are two problems that probably define that. And we talked about this in our editorial. One, I think, is I do think there still is a little bit of distrust of the data that underlies those studies, the effectiveness data, which, you know, as you mentioned, really comes largely, you know, almost exclusively out of Asia. And I think there just is that there's a need to make sure that these are replicatable, you know, in other systems. I don't think there's any biologic reason. The question is, are there systems reasons or are there issues with the data? And I think there just is some level of distrust of that on the part of some people. And that's why, you know, it's not like a level 1A guideline right now, because if the data are truly as they are, with a mortality difference and a reduction in stent thrombosis and improvement in outcomes, it should be as high as, you know, aspirin, you know, on our recommendation list. And then the second is, you know, again, this issue of sort of perspective, which is that in the United States, at least, the amount, you know, of additional reimbursement to the physician isn't that much, and probably is out of whack with the value that it provides. And so I think that, you know, the economics direct us to say, you know, we should, you know, if we trust these data, we should be doing much more of it. And then we have to, you know, then we have to switch over to the sort of implementation hat and figure out how can we incentivize people to do that much, you know, much better. But I do think, I mean, I'm very hopeful that the 2 big randomized trials that are ongoing, Illumian 4, and I forget the name of the one that Ron Waxman's running with ultrasound, but you know, that those will demonstrate at least congruent benefits so that we can get the whole field aligned. How does that set with you? Does that make sense? I mean, I feel like
that definitely makes sense. There's the improved study that Ron Waxman's running, and then there's another one in Europe. But I spent a lot of time talking with government about this, and you even made reference to our publicly funded healthcare system. And of all the healthcare systems in the world, you would think it's the one that cares the most about avoiding emergency room visits, long-term dual antiplatelets, because the government pays for drugs, et cetera. So it's an interesting spot that I spent a lot of time talking about. So thanks.
Yeah, is utilization in Canada any better than around in the US?
We're pretty similar to the US.
Yeah,
it's growing, but it's similar to the US.
Yeah, I really think I mean, I do think, you know, some of it is just, you know, ease of use and interpretation, and certainly, you know, OCT, where, you know, which is becoming much, you know, so automated, even, you know, Rich Schlafmitz, my boss, can do it. You know, it's, you know, it's coming, but it is slow. And I really think, you know, we're counting on at least one of these 2 big trials to have, you know, supportive evidence, I think.
Thank you.
From it. Eric, are there other questions, or should I?
No, I think let's keep going, David.
Okay, let's go. So let's go on to, you know, my favorite example for the last 10 years, which is TAVR. And again, I know there's lots of folks at your institutions that do plenty of transcatheter valve replacement, but probably still don't get to do as much as they think they ought to. And I want to really kind of dive into the value proposition here. Now, everybody knows transcatheter valve replacement. It's been approved in the United States for a little over a decade. And if you think back about the history of it, it was originally really developed for the inoperable extreme risk patients. And then after those initial trials, we started expanding the indications through additional trials to high risk patients and the elderly, regardless of surgical risk. But as TAVR was beginning to evaluate, really underlying it for, for the entire time has been this concern about the value, about the affordability of it to a healthcare system, and the value that it's providing given the age and the complexity of some of the patients that we treat with transcatheter aortic valve replacement. And, again, it's important just to think back about this a little bit when it was first coming out, and remember, what TAVR looked like when it first came out. And so I just want to tell a small anecdote. So this is, I'm going to show you a photo in just a second the TAVR team at Mid-America Heart Institute. So we started doing TAVR in 2008 as part of the original partner trial. And we were very excited to get enrolled in going there. We were the 20th center in the United States to do this. We were super excited. And we had our first case coming up. We went to the newspaper in Kansas City, and we said, this is going to be a big story. This is going to be a revolutionary technology. You want to cover this? And they said, yeah, absolutely, we do. So we want you to set a reporter out. They, and then they said, we want to get some photos to run with the story. And I assumed, I don't know how this happens. I assumed that we would just kind of get everybody in the room and we put like a fellow under the drape and everybody be standing there looking nice and calm and neat doing this, mock procedure. And they said, no, we have to, we're the newspaper. We have to have the real news. So we have to come and actually take, photos during a procedure, get the HIPAA consent and all those things. So we did that. So we got consent from our very first patient undergoing transcatheter aortic valve replacement. This was a 87-year-old woman with steroid-dependent COPD. She was 5 feet tall, weighed 90 pounds. She was, probably the prototypical candidate for a TAVR. And what I want to show you is the photo that ran on the front page of the Kansas City Star, our main newspaper, the day after our first ever TAVR procedure at the Mid-America Heart Institute. And so this is our procedure. You can see it's a bloody mess. And, I just can remember all of my friends and, family and everybody saying, we thought this was less invasive. What's going on here? This lady was so small. We basically unzipped her entire femoral artery, putting in the 24 French sheath in this little lady. And we spent the better part of the day repairing this, this femoral artery. But what I actually really like about this photo, more than all the blood and the fact that it looks like I'm coming out of a butcher shop, is that it actually shows the whole heart team, which has been, at least in the United States, one of the real revolutions of TAVR, not just the technology, but the whole system of using it. And you can see here in the photo, you can see my partner, Aaron Grantham. You can see myself. This is Trip Zorn, our cardiac surgeon. You can see our cardiac anesthesiologist, Michelle Haynes here. And you can even see the hand of Mike Main, our echocardiographer. So the whole heart team is captured in this one photo along with a lot of other unnecessary accoutrements from it. So this just, I think, is also to tell us that some of the things I'm going to tell you are a little bit of ancient history and things have moved on. We don't get this very often in TAVR these days, fortunately. But when TAVR came along, there were major concerns about the cost, and the cost largely because of the cost of the valve itself. Still in the United States today, a TAVR valve costs about $32,000. That you get little discounts off of it, but it hasn't started to really come down like we thought it might. The costs are still up there quite high, although I think as more competitors come in, we expect those costs to come down. And so when TAVR was first getting started, we were really privileged to work with the partner investigators to develop the mechanism for evaluating the value of TAVR right in the clinical trial. And so this is the very first TAVR trial. This is partner B. This is the inoperable trial, the trial that will never be repeated again, which showed a major mortality benefit with TAVR compared to medical therapy. And so the first question we had to ask is, how expensive was it to deliver this care to these very sick patients like the one that I showed you in the photo? And so this is the initial cost of the hospitalization for TAVR in the partner B trial. You can see about $42,000 for the procedure. The vast majority of that was the valve. The rest of the hospital stay was not cheap. It was another $30,000 because the length of stay back then was 10 days for these very ill patients. And then there was about $5,000 worth of physician costs, including the cardiologist, the surgeon, the anesthesia team, the echocardiographer, all those things. So it cost about $78,000 to get in the door and out the door with your TAVR in the partner B trial. Over the next 12 months, there were a lot of good cost offsets. Remember, we have to think about those induced costs, and the induced costs can be negative. And so there was a very substantial reduction in hospitalization seen with TAVR, which saved about $26,000. And then most of the other aspects of care actually were not all that affected. And so when we added this together, the total 12-month costs in the partner B trial the net cost was about $52,000 higher with TAVR compared to medical therapies. Much, much higher, obviously, although not nearly as high as the cost of the initial hospitalization. So if you will, this was kind of the bad news, is that TAVR had a lot of cost offsets, but it didn't pay for itself by any means. The benefit of TAVR, of course, was the life expectancy gain. And this is the data that we had in hand when we did this first cost effectiveness analysis of TAVR versus medical therapy. You can see the survival curve for the control group, the survival curve for the TAVR group, and then the difference between those curves shaded here in orange was 0.49 years, about a half a year of added life expectancy that we observed during the first 2.5 years of the trial. But of course, that's not the end of the story. That would be the end of the story if we only cared about living for 2.5 years, or if we assumed that all these patients who were alive from TAVR actually died at month 30, but that didn't happen. So we actually needed to extrapolate these further in order to really understand the life expectancy gain. And so this is that same set of data now just squished over to the left. And then when we fit mathematical curves to that and then extrapolate that forward, the gain in life expectancy is now not about 0.5 years, but actually about 3 times that much, about 1.9 years. And you can see now that we actually did a pretty good job with our extrapolation. These are the 5-year data that were ultimately published when the trial was completely finished. And so we did a pretty good job of hitting the mark with those curves, which actually is probably a feature of the fact that so many of the patients had already died, so we didn't have very far to extrapolate. Other studies that we do, sometimes we have a lot more extrapolating. But the gain in life expectancy was about 1.9 years. And so now we have enough information to try to understand whether TAVR is really cost effective for these extreme risk patients. And we plot this on the cost effectiveness plane. What we're going to show here on the x-axis is the gain in quality adjusted life years, or actually life years in this case. And then the y-axis, the difference in lifetime healthcare costs. And then here is the cloud of points. This is the uncertainty, the joint uncertainty in those two parameters. We estimate by bootstrapping, by replicating the trial about 1,000 times. Here is the average here, which is the cost effectiveness ratio. So a gain in cost over the lifetime of about $80,000 and a gain in life expectancy after discounting of about 1.6 years. If you divide those by one another, it comes out right around $50,000 per year of life gained. And I swear I didn't game this or anything like that. It came out right to that number all by itself. This diagonal line is a threshold of $50,000 per year of life gained. And you can see it sort of bisects that curve. So that's our high value threshold. But here is a intermediate value threshold of $100,000 per year of life gained. So this one graph tells a lot of information. The first thing that it tells us is that there's no way we're saving money with TAVR. Every single one of these points is in that upper right-hand quadrant, meaning it's extending life, but it's also costing us more money. But we can also say that we are very, very confident that it is at least providing intermediate value and kind of 50-50 on whether it's providing high value care. But the issue about the saving money is an interesting one. When we started this study and we were working with Edwards, who was the sponsor, they were convinced that this was going to be, not only, a great therapy, but it was going to save the healthcare system a lot of money. And I was always worried about that. And I just had this nagging doubt that that was probably not going to be the case, because it is the case for many things. And it actually turns out, so why is it that we're not saving money? And it actually turns out that even if you gave away the valve, if the TAVR valve was free, you still wouldn't save any dollars for the healthcare system. And the reason for that is really, is conceptually interesting once you sort of see the data. Two things. One is that the control patients, who are very expensive to keep alive, they die too quickly. They don't actually accrue a lot of cost because they die so quickly. And then the second, probably even more expensive, is thinking about who these TAVR patients are. They are elderly, they have multiple comorbidities, and they are expensive to keep alive. So even though we have cured them of their aortic stenosis, we haven't cured them of being 85 years old and having all the other things that come along with being 85 that made them extreme risk to begin with. And with those two things in mind, we are not going to save money ever in our lives with transcatheter aortic valve replacement, at least compared to medical therapy for these inoperable patients. But, again, going back to that value statement, we're right here, on the sort of border between high value and intermediate value, a very reasonable place to be. So that's the extreme risk, group of patients, higher costs, but a substantial gain in quality adjusted life years, really providing intermediate to high value. We have subsequently gone on to repeat this exercise in a number of other TAVR trials. So then we went on to the Partner A trial, which was very high risk, STS risk score of about 12. The costs actually over over the lifetime were similar here. And there was a very small gain in quality adjusted life years, really due to the early quality of life benefit. And so this is kind of on the border between economically dominant, meaning saving money and saving lives, and at least, and certainly provides high value. Then we moved down the risk spectrum to the high risk patients. This was the core valve high risk population. Here, the costs were higher, but actually there was actually an increased gain in quality adjusted life years because there was a small survival advantage. And again, it came out somewhere in the $40,000 per quality adjusted year of life gained range, so intermediate to high value. And really the question for the last few years has been, where were we going to end up in the intermediate and then ultimately in the low risk groups? These groups are very clear that we're providing good economic value for our patients. What about the intermediate risk group? And so we had, the opportunity to continue this exercise, and I want to really share some of the details here with you around the trial that we did in the Partner 2A trial. So this is the intermediate risk trial with the balloon expandable Edwards valve. It was a large trial, about 2,000 patients with severe AS and intermediate surgical risk. They were then stratified as to whether they were eligible for transfemoral or non-transfemoral access, and about a quarter of the patients in this trial got non-transfemoral access. And then the randomization was to TAVR using the balloon expandable SAPIEN XT valve or surgical aortic valve replacement, and it was stratified by the type of access. So you can actually look at it almost as two randomized trials in one. The economic methods were a little bit interesting for us. There is something which I've really enjoyed exploring over the last couple of years. The analysis was a U.S. healthcare system perspective, so it's not directly applicable to Canada, but I think close enough. And what we did here is we actually observed the 24-month economic data, and then we did patient-level lifetime projections of survival and quality adjusted life expectancy and costs. But the really cool thing about this study is we were able to actually link the patients from the trial with Medicare claims, which is hard in the United States and Canada. I think it's probably pretty easy to do this sort of thing. So if you have a good trial and you can link it up with Medicare claims, and again, these are all elderly patients, so almost everybody is in Medicare, we can get complete capture of all of their medical care costs. So this really is the true cost to the United States healthcare system that I'm going to be showing you. So the index hospital costs, the procedural costs were $22,000 higher with TAVR compared to surgery, again, driven largely by the cost of the valve. But there were tremendous savings just during the initial hospitalization, again, about $18,000 worth of cost offsets from reductions in ICU and non-ICU length of stay. There were small differences in the physician cost. And so at the end of the initial hospitalization, TAVR was not $20,000 or $30,000 more expensive than SAVR. It was down to about $3,000 in the United States. It didn't pay for itself, but it got pretty close during the initial hospitalization. But where things really stood out is during the follow-up period. So this is the 24 months that we observed. And remember, these are data linked up to Medicare. And what we saw here was tremendous cost savings to the healthcare system. Certainly in the first 30 days, about $4,000, and then another $7,000 between 30 days and 6 months. And then it really leveled out and stayed pretty flat for the rest of the time. And what was going on here in those first 6 months? Well, anybody who is taking care of patients who had cardiac surgery know exactly what's going on here. These are costs for rehabilitation, for skilled nursing facilities for patients who had complications, and for early rehospitalizations, which are substantially higher in patients who undergo surgery. But nobody had really ever quantified what that savings is. And so now we've got some real cost savings here. We've got another $9,000 worth of cost savings to apply. And so when we add this all together with the initial cost, the net cost at the end of 2 years with TAVR was about $6,000 less than with surgical aortic valve replacement. So real, meaningful cost savings here, driven largely not by the in-hospital side, but more by the out-of-hospital and the post-discharge side of things, which I think is really gratifying and really shows the difference between a true minimally invasive technology and major cardiac surgery. Now, what about the denominator? That's the numerator of our cost effectiveness ratio. So here is the denominator. These are the survival curves that were observed during those first 2 years of the study. And then we projected those forward, again, making some very basic assumptions that, whatever benefit that was there gradually attenuated over time. And you can, again, you can barely see the difference between these two things, but these patients lived for a fair period of time. And so we had an in-trial gain in quality adjusted life years driven mostly by the early quality of life benefit of about 0.07. And then the entire life expectancy or quality adjusted life expectancy gained about 0.18, 0.2 quality adjusted life years, which sounds very, very small, but actually when you start looking at things in cardiovascular medicine, this isn't bad. And again, this is probably pretty reasonable for what we can expect with intermediate risk patients, because we're comparing against surgery, not comparing against medicine anymore. And so when we put this now into the cost effectiveness plane, recall that for the extreme risk patients, we were up here in this upper right-hand quadrant. For these intermediate risk patients, we are largely down in this lower right-hand quadrant. And if you remember, that lower right-hand quadrant is really where you want to be. We are gaining quality adjusted life years on average for our patients, and we are saving costs. And in fact, over a lifetime, we projected cost savings of about $8,000 per patient, and a gain in discounted quality adjusted life years about 0.15. This is what we call economically dominant. This is, again, we're adding value back into the healthcare system. And if we look at that $50,000 per quality adjusted life year threshold, we can see that there is, 0 of our points are above and to the left of that threshold, indicating that we are essentially 100% confident that TAVR for these intermediate risk patients is going to be a cost-effective therapy. And we are 84% confident that it's going to be an economically dominant strategy. So really a win-win for TAVR in this case. So now we have this intermediate risk group filled in. We have lower costs by substantial amount. We have a moderate gain in quality of life years, clear economically dominant strategy. And I would say that at this point, the intermediate risk group of patients is probably the true sweet spot for transcatheter aortic valve replacement. They're healthy enough to really benefit from the TAVR. They're healthy enough to live a long period of time, but they're not so healthy that they recover, immediately from surgery, which maybe is the case a little bit for the low risk group of patients, which we'll talk about in just a couple of minutes. So that's kind of, where we were up until just, a couple of weeks ago. And I'm going to share with you in a couple of slides, the data we presented at the TCT meeting a couple of weeks ago. So TAVR is generally cost effective. But one of the other things we can learn from this, entire approach, this modeling approach to understanding the value of our technologies, is when TAVR is not cost effective, because I think that's also equally important as understanding as when it is. And so there's a couple of points I really want to highlight from our research. So one of the places where TAVR is not cost effective is when life expectancy after TAVR is less than about 3 years. And why do I say that? Well, here is, again, an analysis of the PARTNER B trial, again, compared to medical therapy, where we value our assumptions about the life expectancy after transcatheter aortic valve replacement, and we look at how that affects the cost effectiveness ratio. And what you can see here is as that life expectancy increases, and remember, it was somewhere around 3 years or so in the PARTNER B trial, that cost effectiveness ratio progressively comes down. And so if you're willing to spend $50,000 per year of life gained, maybe that's the cost effectiveness threshold in Canada, then you need about a 3-year life expectancy in order to make TAVR for an extreme risk and inoperable patient able to be cost effective. If you're in the United States, you could spend a little bit more. Maybe we could spend $100,000 per year of life gain, maybe a 2-year life expectancy, but you certainly don't want to be down in here where you're only going to get a year worth of life expectancy out of the TAVR procedure. So it's very important for us to think about how long that patient is going to benefit. And if you look at the indications and the coverage decisions for TAVR in the United States, they say, they imply that you want the patient to be able to have at least a 1-year life expectancy in order to gain some of the real value provided by the therapy. A second area when TAVR is not cost effective, which is kind of the flip side of that coin, is when quality of life doesn't improve. Remember, TAVR provides 2 major benefits to our patients. It allows them to live longer, but it also allows them to feel better. And many of our elderly patients care more about quality of life than about the duration of life. And so this is an analysis where we took the data, this yellow cloud of points, which was the PARTNER B inoperable group, and we mathematically said, okay, we're going to give you your survival benefit, but we're going to take away your quality of life benefit. We're going to assume you don't feel any better whatsoever, but you do gain some life expectancy because we relieved the aortic stenosis, but maybe you have really bad lung disease, or you have multiple horrible arthritis and you're bedbound. So your quality of life really doesn't improve very much. And now you've moved, what you can see is from this area where we were, on the border of high value to where we are clearly not providing high value. And in fact, that cost effectiveness ratio goes up to around $100,000 per quality adjusted year of life gained. And so if you have a patient in whom you don't think they're going to feel much better after the TAVR, maybe that's not really providing high value care to that patient. And that has really led us to this whole idea of whether we can predict futility. And this is not really directly related to economics, but I think it's just something interesting to think about in an area that we've also been working very much on that I wanted to share just briefly with you before finishing up, because this, really ties into how do we establish value, how do we understand it, and how do we apply these methods in practice. And so Suzanne Arnold, one of my colleagues at the Mid-America Heart Institute, and I, about 10 years ago, when TAVR was really just getting started, we started thinking about how are we going to conceptualize the idea of, the outcomes of TAVR, and how do we integrate the idea of getting a gain in survival against a gain in quality of life. And we came up with this idea, this kind of conceptual idea of a poor outcome of TAVR. And we did this by really just plotting the KCCQ score, a heart failure scale that we've used extensively to study quality of life in TAVR, at baseline and at 6 months from the early partner trials. And you can see there is kind of this very big cloud of points. And then we just sat around and we started drawing, shading this graph in to try to figure out, well, what would be a reasonable definition of a poor outcome for these patients? And we, decided somewhat arbitrarily, but also with some input from patients and from nurses, that this pink area was where we thought that, at least a reasonable place to draw an initial line. So these, this whole rectangle down here in this lower left-hand quadrant, these are patients who 6 months after their TAVR, they have a KCCQ score of less than 45. That means they're still in class 4 heart failure, even after their TAVR. That's probably a poor outcome, even if you're alive. And then this group here, these are patients who actually started out with reasonable health. And these ones actually, they got substantially worse. And then here in this upper left, this upper triangle, these are patients whose quality of life declined using the KCCQ by at least 10 points. And so we kind of shaded in this area and we said, this is probably a reasonable definition of a poor outcome. And once you define a poor outcome this way with these 3 parameters, then we can start to, conceptualize the other group, they're alive and well, and we can start to model this. And we actually did, a series of studies where we, generated, predictive models and validated these predictive models. This is the original one that we did in the partner trial. And you can see the predictors here of what predicts a poor outcome. Patients with AFib, higher creatinine, oxygen dependence is very important, lower gradient, lower mini mental status exam score, poor physical function at baseline. All of these predicted a poor outcome in the early partner experience. We subsequently went on and validated this in the core valve data. I don't think I've ever seen this before. There's a validation study where it actually performed, basically as good in an external data set, with maybe perhaps even a better calibration than it was in the original data set from which it was derived. And then we, started looking at the population of patients in the partner trial who fit into these different categories. And so we, again, generated some ranges of probabilities of having a poor quality of life. And so we made it kind of into quartiles here. And what I want you just to pay attention to is this very high risk quartile. So we were able to identify within the partner trials, these patients who were selected for randomized trials, about 1 out of 10 patients who were at very high risk, who had a 73% risk of having a poor outcome at a year, either being dead, shown here in red, or having a persistently poor quality of life, shown here in blue. And the question that I would ask, and we can maybe talk about this afterwards, is whether this is really futility. Have we gotten to a definition of futility? If you had a patient and you knew they had a 73% chance of being dead or feeling poor prior to undergoing a TAVR at a year later, is that somebody you would offer the procedure to? Would you want to do something else? This is the best we've been able to get so far. We can't get much higher than that. There may be biomarkers or imaging findings that we don't have access to right now, but this is the best we've been able to do. But it really, I think, makes this concept of futility a little more concrete, and it makes me think about it quite a bit. Let me just finish up then with a couple of last points about when TAVR is not cost effective. My surgical colleagues always like when I point out that TAVR is not cost effective when surgical AVR is equally effective and less costly. When is that? It's when we need to use a transthoracic access. So in the early trials, most of the patients were treated transfemorally, but still about a quarter of them were treated transthoracic. And this is that partner 2A trial, the intermediate risk patients. If you segregate them into the patients who were suitable for transfemoral access versus transthoracic access, you get wildly different results. The transfemoral access, in fact, is even more cost effective than it was in the main trial. It's cost savings of almost $12,000 and about a 0.3-year gain in quality adjusted life years. But look here at the transthoracic access, transapical or direct aortic access, positive costs, lower quality adjusted life years. We're in this undesirable upper left-hand quadrant. And so there is no way that we should be doing in 2021 transthoracic access on anybody who is a surgical candidate. That's, very, very clear. It just is not a good value for the patient. It's not a good value for society. We should just, if we haven't stopped, we should stop at this point. And then finally, coming to the low-risk patients, TAVR is not cost-effective if long-term mortality is lower with SAVR. And why do I say this? Well, here is the data we just presented at the TCT meeting on Partner 3 cost-effectiveness. This is the low-risk patients, the patients who were 74 years old, had really nothing wrong with them, whatever. They were ideal surgical candidates. And what we saw over 2 years of follow-up in Partner 3 was that it was actually economically dominant at 2 years. It was in this lower right-hand quadrant. It wasn't as cost-saving as an intermediate risk group because the surgical patients did much better. There weren't as many rehab costs. There weren't as many rehospitalizations, but we did save about $2,000 per patient. The gain in quality adjusted life years was small, again, because there really wasn't an important survival benefit. There was an early quality of life benefit here. But we had about an 84% likelihood we were dominant. And if we extend this over a lifetime and we assume no difference in survival or cost between 2 years, well, we're 95% confident that it is a reasonably cost-effective therapy for these low-risk patients. But what if the mortality is different? What if the mortality is different? And the answer is very different. So here is a sensitivity analysis that we've done looking at the long-term hazard ratio for late mortality with TAVR versus SAVR. And you can see, again, if it's 1, TAVR is economically dominant. This is the cost effectiveness ratio now for SAVR. And what you can see here is that as that ratio gets above 1, even relatively small amounts above 1, very quickly surgery becomes the preferred therapy, at least from an economic perspective. And if you're willing to spend, $50,000 per year of life gain, anything above about a hazard ratio of about 1.04, surgery becomes the cost-effective therapy for these low-risk patients. And so what does this really mean? Well, it means we're still uncertain about the cost-effectiveness of TAVR for low-risk patients because we're really uncertain about this late hazard ratio, and we need to continue to follow our patients out to 5 years, 10 years, maybe even longer to really understand the true value of these therapies out over the long term for our society. So let me just finish up now. I know I've gone a little bit over my time with the 4 take-home messages, and then see if there's any other questions. The most important take-home message here is that cost-effectiveness analysis isn't about saving money. It's actually about saving lives, maximizing the number of lives that we can save, recognizing that we don't have an infinite healthcare budget to spend. Number 2, I emphasized this earlier, our treatments are not cost-effective unless they're effective. We have to do our basic clinical research to show clinical benefits in order to justify the cost of anything that is more expensive than our standard of care. Hopefully, some of these examples from TAVR and other work that I've done really have shown you some of the value of applying cost-effectiveness analysis to medical technologies, to new advances in interventional cardiology. We can really supplement our traditional mechanistic, our biologic, and even our outcome studies to try to develop more evidence-based guidelines for device utilization and treatment strategies. And finally, I continue to believe that technologies that increase the overall cost of medical care may be acceptable in the future, but this is only the case if we as a clinical community of thoughtful cardiovascular practitioners can demonstrate improved clinical outcomes that are meaningful to our patients. And by that, we generally mean increased life expectancy, reduced symptoms, or improved quality of life. And I think this is really just a call to action to continue our tradition of excellent research in cardiovascular medicine to really demonstrate the value of the care we provide. With that, I will stop and be happy to take any questions if there's more time.
Great, thanks. David, perhaps you can maybe take down your slides and we can just show the audience. I know Sam had a question. Sam, do you want to go ahead? Maybe we'll take a couple of questions if possible. Sam?
Thanks, David. That was a fantastic talk. It was wonderful. So, I think your part about perspective hits home. So to be provocative here, we pay about 50% or 2/3 the costs of our TAVI valves as our colleagues 90 minutes from us south of the border. So is there a negative to these cost-effective analysis, given that it is dependent upon looking at a product that is provided by a third party who has spent R&D money and lots of money trying to make a profit on these valves.
I mean, there are everything has two sides of the coin, costs and effects, and these types of analyses. I think that I'm going to give two answers. One is I think it's okay. I mean, over the years, I've convinced myself that it's not only is it okay, but it's okay for companies to use this kind of information to set their prices if they want, because the idea here is we're trying to use this in a way to inform our societal decisions, and the companies would be silly if they didn't. If in the UK. They have a very strict threshold. If you're not under 30,000 pounds per quality adjusted year of life gain, don't even come to talk to the NICE organizations about getting your drug or your device on their formulary. And it provides some incentive for the therapies. NICE just came out with their recommendations for transcatheter valve replacement, and they said it's only cost effective for high risk and for extreme risk patients in the UK, and it's really and so surgery should still be first line for the intermediate and high risk patients. But they also provided in that document. And they said, well, if the cost of the TAVR valve wasn't 20,000 pounds, but it was 16,000 pounds, it would actually be quite reasonable to do TAVR. And to me that certainly looks like a shot across the bow to the device manufacturers of get your price down to 15,000 pounds, and we'll all be happy. So I don't think that's a problem. Where I do think there is a problem or an issue, which always worries me a little bit, is a different issue, which is premature rejection of favorable technologies, of things that, where we just didn't know how to use it initially. And imagine again, if you, had a strict, cost effectiveness threshold on TAVR, and and it cost $70,000 to do a TAVR procedure like it did in the first, couple of years, you'd never, think to bring this to, low risk patients. So you have to have, so doing an economic evaluation sort of prematurely when you don't know the population, when you don't know how to apply the technology, could lead to premature discarding of a very promising therapy that was eventually going to yield major economic benefits too early. So I think that's the one area where I think there can be a negative, and we have to be very cautious about again moving too early with these types of analyses, both on the clinical side but also on the cost effectiveness side. Does that get to your question, Sam?
Yeah, absolutely. I mean, I think you've hit the nail on the head, which is that we haven't seen, even in Canada, we haven't seen the valve costs dramatically drop, but yet we're already below what you're paying in the States and what you're paying in Europe, et cetera, et cetera. So it's how we're moving forward, perhaps not as fast as we would like.
Right. I think it's, so what is a TAVR valve is 15 to 20,000 Canadian?
Yeah, we'll give it to you for 25 if you want to buy it from us.
Okay, so all right, so I have a promising import business in front of me.
A little bit cheaper.
If I don't get stopped at the border, I guess.
But I think in the interest of time, I would like to thank David and for Eric for kind of getting David on board to give grounds. I know this is one of the best cost effectiveness analysis, like for the trainees, this is just amazing. So I hope that you make it to Austria at some time soon. If not, have a good holiday in New York. Thanks a lot again, David.
Oh, thank you very much for inviting me. It was really great to be here. Hey, Harindra, I see you there. Good to see you, and good to see so many friends and colleagues, and have so many good questions. I look forward to coming back at some point and actually getting to enjoy some time in person with you guys.
Yeah, for sure. Thanks a lot.
Take care.
So long. Thanks a lot, David.
Bye.
Bye-bye.